Welcome to OHA's weekly COVID-19 media briefing. Thank you for joining us this morning. Today we're going to have Patrick Allen, the Director of the Oregon Health Authority, who will provide an update on vaccinations, Dr. Dean Sidelinger, who will provide an update on the latest that our forecast is telling us about the situation in Oregon and what we can expect to see going forward. We've got guests from Oregon State University, Tyler Rednecki, and Brett Tyler, who will talk about identification of variants in COVID-19 and the different ways that they have been doing that. And Brian O'Rourke from Oregon Health and Sciences University, who will also talk about variant tracing. Just a reminder for folks, this briefing is for media. It's an opportunity for media to ask questions. If you're a member of the public, you're welcome to continue to listen in. We're going to reserve the question and answer sessions for media. If you are a member of the public, just want to let you know that we are holding a Facebook Live on February 2nd with a focus on schools and COVID-19, and we'll have Oregon Department of Education Director Colt Gill and OHA Deputy State Epidemiologist Dr. Tom Jean providing information, answering your questions. If you are a reporter and you want to ask a question today, please identify yourself in Zoom. Click on the participants button at the bottom of the screen. Name yourself and provide your media affiliation. That way we'll know that you're a reporter. And then put your questions into the chat and put your name into the chat, and then we will make sure we get you into the queue, and we will call on people in order of their questions. So thank you again for joining us, and let me turn it over to Director Patrick Allen.
Good morning. I'm Patrick Allen, Director of the Oregon Health Authority. This morning I want to give an update on the pace and progress of Oregon's COVID-19 vaccination program. As Rob indicated, I'm joined today by Dr. Dean Sidelinger, our State Health Officer, who will update you on the COVID-19 situation in Oregon and tell you about our latest pandemic forecast. We're also joined by OHA Chief Financial Officer Dave Baden, who's available to answer questions about vaccine distribution. In addition, we're joined by researchers from Oregon State University and Oregon Health and Sciences University, who will share the latest news about the detection of variant strains of the COVID-19 virus in Oregon. I'll be joined by Tyler Rednecki, PhD, OSU Associate Professor in the School of Chemical, Biological, and Environmental Engineering, and a TRACE co-principal investigator, and Brett Tyler, PhD, Director of OSU's Center for Genome Research and Biocomputing, and co-principal investigator of TRACE. I'll also be joined by Brian O'Rourke, PhD, Associate Professor of Molecular and Medical Genetics at OHSU, and co-lead investigator of the OHSU SARS-CoV-2 Genome Sequencing Center. I appreciate all of them being here today. First, let's start with vaccinations. Despite our limited supply of doses, Oregon continues to vaccinate eligible people at a high rate. The steps we took earlier this month to speed vaccination throughput are working. Oregon remains ahead of most other states in the percentage of our population who've received vaccination and the percentage of doses vaccinators have administered. Oregon's on track to vaccinate a critical mass of phase 1A. As we approach the end of January, Oregon vaccinators have fully vaccinated more than 63,000 Oregonians, and another 318,000 have received first doses. As expected, we're at least 3/4 of the way through the estimated 300,000 to 400,000 people in phase 1A groups, which include everyone from nursing home residents to ICU nurses to healthcare interpreters, emergency medical technicians, staff in tribal clinics. As of today, 90,000 Oregonians 60 years old and above have been vaccinated. However, we know that not every county is at the same stage. We're adjusting allocations among counties. Counties that received higher allocations or had response rates that put them in a position to tell us they were confident they could move beyond phase 1A and education, early learning, childcare will get less vaccine next week, while others will get additional vaccine to accelerate their progress through those groups. In other words, if you're a county that believes you've vaccinated all your eligible populations, we're not giving you additional doses to vaccinate your ineligible populations. All indications tell us educators, child care workers, and early learning center staff are on track. Counties are using the 61,000 doses we've allocated for this week and next week to vaccinate educators, and we believe we're on pace to vaccinate a critical mass of of that population by the time people aged 75 years of age and older become eligible the week of February 14th. Now let's look at the numbers. Just over a month after the first COVID-19 vaccines arrived, let me share with you where Oregon stands in our vaccination rollout. As of today, we've administered 382,374 total first and second doses of COVID-19 vaccines. Yesterday, Oregon vaccinators administered 15,813 doses. Oregon is tied for 15th in the nation in percentage of population given at least one dose at 6.8%. And we're tied for 23rd in the nation in percentage of vaccine administered at 56%. Over the past week, Oregon vaccinators met Governor Kate Brown's daily target of administering 12,000 doses per day. As of today, the 7-day rolling average is 14,597 shots per day. Now let's take a closer look at our supply of doses and our timelines. This slide shows the basic challenge Oregon and other states face: a shortage of vaccines. More than 6 weeks into our vaccination effort, at our current level of supply, it would take more than 14 weeks to vaccinate all the approximately 1.2 million people who are eligible or will become eligible to be immunized. Here's an update on our supply of doses and how we allocated these supplies this week. The federal government has notified OHA that our Moderna Prime or first doses will increase from 25,000 per week to 35,000 per week. We expect this to continue going forward. Currently, that means our total allotment of Prime doses is about 65,000 doses per week. This week, we made decisions on vaccine that will be delivered next week. 7,800 to the federal pharmacy program serving long-term care facilities. They didn't need the full amount that they expected. 17,000 to continue to provide vaccine to hard-to-reach 1A populations in the Tri-County region. To date, the Tri-County region has received over 221,000 doses to vaccinate 1A populations. 3,000 doses as a tribal set-aside. 31,000 doses for K-12 early learning and childcare. And 12,300 doses for the 1A population in the rest of the state. I want to be clear. Oregon has the infrastructure in place to vaccinate more people who are eligible to get immunized at a faster rate than our limited supply allows. If we receive more vaccines, we can vaccinate more people sooner. Until we do, all of us, including people like me who are not yet eligible to get vaccinated, need to be patient. And every day, Oregon Health Authority teams are doing everything we can to open more vaccine distribution channels. We want to support our hospital partners who are operating mass vaccination clinics that can serve large numbers of people and provide a consistent and reliable supply of doses over the long term. We're starting to use pharmacies and getting vaccine to providers that regularly serve seniors. We're partnering with federally qualified health centers to ensure that patients whom those safety net providers serve have access to vaccines. And every day, Oregon Health Authority teams are doing everything we can to reach people within our eligible groups whom we haven't reached. We're sending tens of thousands of doses of vaccine available to get vaccines in the arms of those who can't make it to a mass vaccination site. We're expanding state mobile vaccine sites to supplement the federal pharmacy Part A and Part B efforts. We're exploring ways to expand transportation options to get to people who are homebound. We're working to enroll other trusted, culturally responsive, community-based organizations as provider locations to increase access, especially in communities where we may see higher rates of wariness toward government and vaccine hesitancy. So what does the current supply mean for our timelines? In general, we're aiming to reach approximately 70% of each eligible population vaccinated before we move to the next eligible group. That's a guidepost, not a hard and fast number. For phase 1A, at a statewide level, we're past the 70% threshold, though we know there's variation by county. For educators, we expect educators to be close to that level by the time we open vaccinations to seniors in a little over a week. As you can see, the educator population is a relatively small bump in the number of people eligible. As we discussed last week, vaccinating educators, early learning staff, and childcare now gives Oregon the best opportunity to open schools before the end of the school year. The next major increase in people who are eligible are seniors. Starting February 8th, more than 800,000 older adults will become eligible over a 4-week period. Without any new doses, we expect to reach a critical mass of seniors by late April or early May. And then phase 1B, we expect to begin opening in May to people in that, and I'll talk more about that in just a minute. But we know counties aren't moving through their eligible groups at a uniform rate. As you can see from this slide, some counties have vaccinated more of their population than others for a variety of reasons. Let's look at where the situation stands at a county level and what OHA is doing to allocate enough vaccines at a local level to ensure all counties are able to work through their phase 1A populations. For next week, our expected allocation of first doses of the Moderna vaccine is 38,400 first doses. Our expected allocation of second doses of the Moderna vaccine for next week is 21,200. As I mentioned earlier, this is an increase of over 10,000 Moderna first doses from last week. Based on our federal allocation for next week, we've prioritized sending vaccines to 15 counties who have told us they need additional doses for phase 1A and to reach more education, childcare, and early learning staff. Those counties include Benton, Clackamas, Columbia, Coos, Douglas, Jackson, Josephine, Klamath, Lane, Multnomah, Polk, Umatilla, Union, Washington, and Yamhill. In turn, 18 counties have told us they have substantially completed phase 1A, and some of us have told us they're already through their K-12 eligible population. They will receive fewer doses next week and will continue to work through their doses on hand. Those counties include Baker, Clatsop, Crook, Deschutes, Gillum, Harney, Jefferson, Josephine, Lincoln, Lake, Lynn, Malheur, Marion, Morrow, Sherman, Tillamook, Wasco, and Wheeler counties. We know our eligible populations aren't distributed exactly evenly across all counties. We know some counties may have populations that are more connected to established health systems, while others have people who are harder to reach. We know not all counties will have the same demand for vaccines and uptake rates. It's important that as a state, we're addressing these local variations and moving forward through each phase together at a consistent pace. The steps we're taking next week will help ensure that all our counties are ready to move ahead when we open eligibility to older adults on February 8th. Finally, let's talk about who comes after seniors. Yesterday, Oregon's 27-member COVID-19 Vaccine Advisory Committee, or VAC, met for its fourth and final official meeting. They recommended 4 groups move forward concurrently once we've vaccinated a critical mass of seniors. Those groups would be adults 16 to 64 with underlying health conditions, frontline workers, which is yet to be completely defined, adults and youth in custody 16 years and older, people living in low-income and congregate senior housing. People who live in multi-generational households would be next in line behind those groups, followed by the general population. As a next step, Oregon Health Authority staff will review the operational and legal dimensions of the Vaccine Advisory Committee's recommendations before we refer them to Governor Brown. The VAC has an optional meeting on February 2nd to discuss implementation issues for these groups. I want to thank the VAC members for all their hard and important work. In particular, I want to recognize the VAC statement that acknowledges the reality of structural racism and the focus they placed on the needs of Black, Indigenous, people of color, and tribal communities. The VAC's call on local public health authorities to identify, engage, and serve people who our healthcare system has often failed. At OHA, we take that call seriously. We're grateful for the VAC's thoughtful recommendations and its challenge for us to do better for everyone in Oregon. Now, before I turn it over to Dr. Sidelinger for an update on our COVID-19 forecast, I want to add this update on reporting of COVID-19 deaths. I'm proud of our data transparency and our continued A+ rating we've received from national data tracking projects. I want to be very clear. OHA made the decision to change how we share data in an effort to get information out in a more timely way and increase the availability of data through an enhanced data dashboard that offers a clearer, more composite, and more complete picture of COVID-19 fatalities in Oregon. We're proud that we're one of the few states that provides this level of transparency. Going forward, you will still get data daily by age bracket in the daily report and on a weekly basis beginning the week of February 8th by age, county, and condition in our weekly pandemic report. Governor's directed us to provide this data weekly and intends to provide us with the resources we need to make that happen. We appreciate her support. Finally, due to a server upgrade, we will not be providing a daily update this coming Sunday. Now let me turn it over to Dr. Sidelinger.
Thank you, Director Allen. Let me begin by providing an update on where things stand with COVID-19 in Oregon. Over the past 2 weeks, we've seen dramatic declines in daily cases as well as our hospitalization. Between January 13th and January 26th, our 7-day rolling average for daily cases has dropped from 1,307 to 712. That's a 45% drop. We are returning to daily case numbers last seen in early November before our winter surge, and Oregon ranks amongst the lowest in COVID-19 cases and deaths. Our latest weekly report showed that 4,119 new cases were reported to us for the week ending January 24th, a week-over-week decline of 48%. To date, we have reported 141,729 cases, including the 976 we reported today. These decreases are a testament to the work of Oregonians in protecting themselves, their families, and loved ones and neighbors by wearing masks, limiting indoor gatherings, and keeping physical distance. Thank you. Hospitalizations are also significantly lower. On December 1st, there were 577 people hospitalized with COVID-19. Yesterday, there were 291, a decline of nearly 50%. Reported COVID-19 associated deaths for the same week also fell dramatically over the past week, from a pandemic high last week of 195 to 72. As of today, we have reported 1,938 COVID-19 associated deaths. Every single death is sad and represents another family who's grieving, another community that's mourning. Oregon ranks amongst the lowest in the nation in COVID-19 associated deaths due to your collective vigilance. We cannot forget the Oregonians we've lost. Some of our neighbors have been especially hard hit: our Latinx, Black, and Pacific Islander neighbors, and our Native American neighbors. And finally, the percentage of positive tests has also fallen to 5.1% from 6.7% just a month ago. While this represents a definite improvement in our overall situation, we cannot forget that COVID-19 is actively spreading throughout our state. 25 of our 36 counties remain in extreme risk, and while there has been some risk level easing among counties, we hope this trend continues in other counties. But for now, the virus remains a threat to all of us. Oregonians have done an outstanding job in recent weeks in driving down the tide of infection. That improvement is reflected in our latest forecast. The new report estimates that as of January 13th, the statewide reproductive number was 0.81. This reproductive number, under 1, means that for each infected person, they pass the disease on to less than one other person, indicating that the spread of disease is slowing in Oregon. And this is the case. It is considerably slowing. Again, that's evidence of our collective efforts paying off. So thank you. Recall where we were in early December, just as Oregonians were returning in for the winter. The modeling then showed that reproductive number was 1.25. So simply maintaining the status quo projected 2,000 new daily cases and 75 people admitted to the hospital. But according to our newest forecast, if we continue along our present course, keeping the virus at bay, we'll see a decline in daily cases to an average of 420 and 13 fewer COVID-19 hospitalizations by February 16th. If we see a 30% increase in transmission, either because we relax our protective measures or see the more contagious variant gain a larger foothold in Oregon, we project 720 daily cases and 24 new Oregonians hospitalized each day. That's about where we stand today. That's the fragile balance we've experienced during COVID-19. And in some troubling news, testing has confirmed that the more easily transmitted virus variant from the UK is present here in Oregon. 2 additional cases were discovered last weekend, and we expect cases of that strain to become more common. This is not unexpected, especially over the course of a pandemic. Viruses frequently change through mutations, and new variants occur over time, and we must remain committed to taking the steps we know prevent the spread of the virus: wearing our masks, limiting our indoor gatherings, and keeping our distance. You are making a difference in controlling the spread of COVID-19 in Oregon. Thank you. OHA is working with labs inside and outside the state to assist in detection of COVID-19 variants. 3 labs in the state are currently doing genomic sequencing for COVID-19 variants, including at the Oregon State University, the University of Oregon, and the Oregon Health and Science University. Most variants do not change how the virus behaves and many just disappear. We believe the available vaccines will prove effective against new strains of COVID-19. But we do know is that the mask, physical distancing, and limiting our indoor gatherings work effectively against the virus and its variants, so we must keep at it. And with that, let me turn things over to Dr. Brian O'Rourke, who will give us the latest progress on genomic sequencing in Oregon. Dr. O'Rourke.
Thank you. I'm an associate professor of molecular medical genetics at OHSU, and I'm co-lead investigator of our SARS-CoV-2 Genome Sequencing Center at OHSU. So by now in the pandemic, probably most of you know that SARS-CoV-2 is the virus that causes COVID-19 disease. And like all RNA viruses, during replication and transmission, the virus has to copy its genome. SARS-CoV-2 has an RNA-based genome, and we know now that it makes on average about one mistake copying that genome every 2 weeks or so. And so early on in the pandemic, we really saw the power of sequencing SARS-CoV-2 genomes to understand the introduction of the virus to communities and its spread. Really inspiring work done by our colleagues up at University of Washington and the Fred Hutchinson Institute through the Seattle Flu Study. And so at OHSU, like most universities, we shut down in mid-March because of the pandemic and the Stay Home Saves Lives order. And during that time, we were able to put together a set of investigators across the campus with diverse expertise in genomics, microbiology, immunology, RNA viruses, vaccines, to put together a team to really jumpstart genome sequencing of the virus for Oregon. And so to do this, what you need is RNA from a positive sample from so either someone who's infected or an environmental sample. We're able to then convert that RNA into something called complementary DNA, which is then a substrate that we can enrich for sequences that are specific for the virus, and then sequence using a wide variety of new next generation sequencing technologies. And so it's actually a pretty simple workflow. The real challenge has been on the logistical side in terms of getting high quality samples to sequence and setting up those relationships between clinical testing labs and labs that have the capacity to do the whole genome sequencing. We were very fortunate in being able to partner here at OHSU with the newly created COVID-19 testing lab that was set up by the Department of Pathology, led by Donna Hansel and Xuan Chen. And since April, we've been receiving all of the leftover positive RNA samples that would normally just be thrown away, and being able to use our genomic expertise to develop cost-effective ways of sequencing large numbers of positive samples. To date, we've sequenced and released publicly over 1,500 different samples of SARS-CoV-2 to a public repository known as GISAID, which has been set up to rapidly share information about the viral genome throughout the world. Through these efforts, I'll just give you a few highlights of what we've seen so far. So one of the first things that we really wanted to do is understand, in the early part of the pandemic, how many times was the virus coming into Oregon, and how did those early shutdown orders affect things? So we saw that in the first 3 months of the virus, we had most of the early introductions, about 20 introductions of the virus coming in from different parts of the world. That was, fairly stable, seeing those introductions change slowly over time. And as things started to open up late in the summer, we saw additional introductions. So all told, we've confirmed at least 29 different introductions of the virus to Oregon in the first 6 months. And since then, we've been working with public health partners most closely with the Multnomah County Health Department Communicable Disease Services Group and their epidemiologist there on tracking how now the existing forms of the virus have been spreading through Oregon. We've also aided in several outbreak investigations at major medical centers, including the Portland VA and at OHSU. As we've done this now for 9 months, every time we sequence a sample, it's likely to have one of these new mutations. And I think it's important to recognize there are kind of different categories of new mutations that have arisen. So kind of the lowest concern are new mutations that you just see one time in a sample that may or may not affect how the virus functions. If those new forms of the virus begin to spread, those then become variants under investigation. And when there becomes significant evidence that those variants under investigation are really different or causing differences in the transmissibility or the severity of the virus, then those become variants of concern. So the B117 variant that has been talked about most recently is kind of the first variant of concern that has arisen. And we are kind of fortunate to be able to have a kind of a canary in the coal mine for detecting this variant, at least for clinical testing, because one of the common methods of detecting COVID-19 in affected individuals is using an assay that uses 3 different probes to detect the virus. And B117 actually causes one of those 3 probes to fail. And so working closely with the pathology lab over the long 3-day Martin Luther King weekend, we were able to rapidly screen through all of the recent clinical samples using that test that had dropout of that probe and identify a presumptive positive on Martin Luther King Day shortly before midnight from a sample that was collected at the end of December. And since then, we've confirmed that that is a true positive through whole genome sequencing and are in the process of screening additional presumptive positives. Taking a quick look at the publicly available data on B117 that's been made available through the handful of recently sequenced viruses, it's clear that it's not just a one-time introduction of B117. The 2 samples that are available in GISAID are clearly kind of distinct cousins of B117 and were introduced to the state from different individuals and not directly connected. And so I think that and the evidence across the country really shows that it's not surprising that we're detecting B117. It's going to be very similar to the early phase of the pandemic where we have multiple introductions of this new variant into the state. And using the tools of whole genome sequencing, we can identify these and track how they spread. And so I think with that, I'll turn it over to the folks at OSU to talk about some of their environmental and follow-up sequencing studies.
Thank you, Brian. And good morning, everybody. My name is Tyler Radnicki. I'm an associate professor of environmental engineering at Oregon State University and a co-PI of OSU's TRACE team. Today, I want to tell you briefly about our sewer surveillance program. What we have known for a while now is that individuals infected with SARS-CoV-2 can shed the virus into wastewater, and that we can detect and quantify this virus at the influent of wastewater treatment plants using PCR-based technologies. The advantage here of this system is by collecting a single sample at a wastewater treatment plant, it is possible to get an unbiased and confidential sample that will give you a snapshot into the viral load of an entire community, allowing you to judge the overall health of the community with a single sample. Additionally, if you continue to sample the same wastewater treatment plant over time, you can see rises and falls of viral loading in that community. So using this technique, my collaborators, Dr. Christine Kelly at Oregon State University, as well as Dr. Ken Williamson at Clean Water Services in Washington County, began sewer surveillance in Corvallis and throughout the county of Washington in early April. After getting established, we quickly developed a collaboration with Melissa Sutton and OHA, and we've expanded our sewer surveillance program to 40 communities across the state of Oregon in 21 counties. In this case, we were receiving weekly samples from these communities and quantifying the viral loads. Additionally, working with OHA, we plan to expand this even further to include cities from all 36 counties in the state of Oregon, as well as increasing our sampling frequency from once a week to twice a week. In addition to monitoring SARS-CoV-2 and wastewater at the community level, working with OSU's TRACE team, we have also been able to monitor SARS-CoV-2 in wastewater at the neighborhood level. Together with our TRACE colleagues, we've gone into 8 communities across the state of Oregon and have quantified viruses at the neighborhood level, allowing us to identify hotspots and spatial distribution of the virus within those communities. Additionally, work on OSU campuses, we have also are sampling 25 locations in Corvallis, Bend, and Newport, including dormitories and congregate living areas. Throughout all this effort, we have learned that we can also use wastewater not only to quantify viral loads in the given communities, but also to identify variants. And so to that effort, we have sent roughly 1,000 wastewater samples to OSU Center for Genome Research and Biocomputing, where Brett Tyler and his team have been sequencing the SARS-CoV-2 and identifying various variants. And now I'll let Brett continue on from there. Brett, you might need to unmute, I'm sorry.
Yep, I always do that. So as I didn't say before, thank you, Tyler. Good morning, everyone. My name is Brett Tyler, and I'm director of the Oregon State University's Center for Genome Research and Biocomputing. My center provides genomics and big data services and training to OSU researchers and their collaborators worldwide. I'm also a co-principal investigator of OSU's Trace COVID project that conducts community surveillance for the virus in communities across Oregon and on the OSU campus. Currently, as Tyler has indicated, my center has sequenced 936 wastewater samples that had tested positive for viral RNA, and we've sequenced 174 samples from participants in the Trace community surveillance who had tested positive. These samples date back as far as late April. In our latest rounds of sequencing from late December and early January, we detected the genetic fingerprint of the UK variant in a sample of wastewater from Bend, Oregon, that was collected on December 22nd. Furthermore, we've detected the genetic fingerprint of another variant that's under watch called L452R. We detected that in 4 wastewater samples from the OSU campus and in samples from the wastewater plants in Albany, Forest Grove, Klamath Falls, Lincoln City, and Silverton. We also detected this variant in 5 individuals from the OSU Corvallis campus. The L452R strain has been in the US since March, but recently has been associated with several large outbreaks in California. Although the L452R strain does not carry the mutations common to the UK, South African, and Brazilian strains that are associated with rapid spread, the L452R strain does carry a mutation in the spike protein that has been shown in laboratory tests to reduce binding by certain antibodies. It's not clear yet whether this impacts the ability of people's immune responses to protect against the virus. There's also no definitive evidence that the L452R spreads faster than most other strains. Nevertheless, we are keeping a close eye on it. As these strains continue to enter our communities, as our findings indicate, We reinforce the importance of all Oregonians being vigilant about protecting themselves, their families, and those around them by wearing at least one correctly fitting mask when in contact with others, limiting indoor gatherings, maintaining social distancing, washing hands regularly, and above all, getting vaccinated when their turn comes. Thank you.
Thank you, Dr. Tyler, and thank you, Dr. Rednicki and Dr. O'Rourke. Back in early December, we were worried, legitimately, that unabated, the virus would overtake us, swamping our hospitals and medical systems with new infected patients. It's a tribute to every Oregonian that we were able to avoid that fate, and by continuing to heed the personal protective measures, we have succeeded in tamping down the virus. Thank you. But if we've learned anything throughout this pandemic, it's that present-day success can quickly be lost if we let our guards down or the virus transmission changes. While it may be true that our pathway out of the pandemic is smoother than it was 6 weeks ago, we have a long way to go. More Oregonians are getting vaccinated every day. I encourage every eligible Oregonian to get the vaccine when it's available and when it's your turn. Together, we will achieve community immunity and prevent illnesses and deaths from COVID-19. But until then, we must continue wearing masks, staying distant, restricting our gatherings, washing our hands, and staying home when we're ill. Today, we're closer to the finish line, but we must not reverse course and let the hard-won progress that we've had escape us. So thank you for your continued fight against COVID-19. And with that, Rob, I think we're ready for questions.
Okay, thanks. We'll go first to Morgan Romero.
Hi, can you hear me okay?
Yes.
Okay, great. So I know you touched on it, Director Allen, but one of the biggest questions we have, I think, especially right now during the pandemic, a lot of people are really paying attention to data, to numbers, to as many details as possible. And right now, several months into the pandemic, you guys suddenly changed your mind and changed the way you're going to report deaths. For a lot of seniors, that's really unfortunate for them. They want to see these numbers. How many seniors are dying? Where are they dying? When did they test positive? What underlying conditions do they have, especially as these seniors wait for vaccinations? Why is it that you guys, I know you touched on it, but kind of more of an explanation on why you decided to now change the way that you report deaths?
Sure. So the basic problem that we were trying to solve for was how do we provide a lot of information about death, the questions that people asked that you just talked about, without creating what was turning into a huge bottleneck in our ability to get all of our data out timely. The information that has been reported in our press releases comes from disparate sources that have to be sort of manually stitched together into that press release. They've got to be pulled out by epidemiologists to do that work out of our disease investigation system and elsewhere, matching death certificates, those kinds of things. And it's a labor-intensive, entirely manual process. And as we particularly 2 or 3 weeks ago, when we were having significantly large numbers of deaths, that bottleneck became a real problem in terms of being able to get our data out. So what we had decided to do was to try to automate that process and provide actually even more information about deaths through the dashboard that we established, so that if people are concerned, are deaths going up or down amongst seniors, and by what age? If they're interested in information about underlying conditions, if they would like to know were they in congregate living or not, were they hospitalized or not, those kinds of things. We tried to put all of that stuff into a dashboard that would automate the collection and reporting of that data. We thought provide more of it and be able to eliminate that manual process. And now we're going to go ahead and roll some of that back to provide more of the daily data about deaths by age and the weekly data on locations. But we still have the dashboard up, which I think still provides really good data to be able to pay attention to what's happening with fatalities in the state.
Okay. Before we go to our next question, I just want to correct something that I said earlier. Our next Facebook Live is scheduled for February 3rd. And again, that will be focused on COVID-19 in schools with ODE Director Cole Gill and OHA Deputy Epidemiologist Dr. Tom Jean. So again, apologize for the error. Again, that Facebook Live is February 3rd. Next question is Keely McCormick from KVAL. Okay, let's go to Lindsay Nadrick from Coin.
No. Oh, can you hear me now? It wouldn't let me unmute for a second. I'm sorry.
Yeah, we hear you.
Looks like it's working. Okay. My question is around the guidance for gyms to reopen today. I know some of that clarification just came out, but it looks like they can do 6 people per room if they're over 500 square feet capacity. Can you explain that? People are wondering, where did that 6-person number come from? What data was used to make that decision? Because I'm hearing from some gym owners who have 40,000 square feet and feel like that's so limiting and when they have this huge space to work with.
Thank you, Lindsay. This is Dean Sidelinger. I'll take that question. The guidance that came out today was an update on the guidance for activities that could occur in some indoor areas in counties that are still in extreme risk. Those counties that are currently seeing high levels of disease spread in the community. For gyms, that 6-person number mirrors the 6-person group indoor gathering size limit. We know that in gyms, as people breathe heavier and with their mask getting damp if they perspire, that the disease can spread further from one person to another. Airborne spread becomes very important. So those numbers were designed 500 square feet to allow that group of 6 to spread out to maintain 25 feet in between them. Gyms or facilities that can then separate groups are allowed to have up to 24 customers on site at a time and limit the interaction between those groups. So the guidance was set to try and open up an activity that we know presents a higher risk for individuals, but lower that risk by keeping people spread out and by limiting the interactions between people.
Okay, Tim Ferretti is next.
Director Allen, you said just a few minutes ago that the OHA was actually rolling back some of the information that you were no longer using in the death rates. Can you further expand on that?
I meant that we were rolling back to go back to reporting some of the data that we said we wouldn't be reporting, that we are reporting now daily the deaths by age group, and then starting with our weekly report in the week of the 8th, we will report the deaths by location with underlying conditions, which is some of what we had eliminated with the change to the dashboard. We'll still keep the dashboard as well, though.
Where did that change come from so suddenly?
The governor.
Thank you.
Mm-hmm.
Oregonian?
Rob, we can't hear you very well.
Oh, apologize for that. Andrew Thien from the Oregonian.
Thank you. Quick question. Has the OSU lab detected the Cal 20C variant, the California variant?
Yes, we have the L452R strain is the California variant. So we've detected that in the wastewater in numerous locations and on the OSU campus.
Got it. Sorry, that wasn't clear to me. Thank you for.
Yeah, these strains do have a number of aliases.
Okay, and then Director Allen, I was hoping for a little bit of clarity on the 17,000 doses to the metro area. I mean, my understanding from documents OHA shared with counties 2 days ago was that 9 counties were receiving little or no doses. The chart you showed earlier has 18 counties. How much of those 18 counties are seeing nothing as a result of those reduced allocations? Can you outline that any further for us?
Yeah, I don't know that I can do that on the fly unless Dave Baden is able to. But most counties are at minimum going to be receiving booster doses, but there are counties that will receive no doses this coming week. Dave, can you provide more detail?
Yeah, thanks, Director Allen. I don't have all of the list of exactly which counties will be receiving 0, but I know, for example, Marion County on there is receiving less, but they still are receiving some doses to their Marion County Public Health Department to continue to do some 1A that they thought they had gotten through, but then they figured out that they did need some more doses. And so we're working very closely with local public health agencies around the state to determine where the 1A populations still are at, and we're trying to get doses where we can to meet those needs.
But we can follow up and provide a comprehensive list of which counties are not receiving any first doses.
And just to jump in quickly on the L452R variant, the OHSU team has also detected that in two clinical samples, the first from late November and most recently from late December, both of which are independent introductions of that strain to the state. So consistent with what OSU is finding as well.
And next question is from Bryce Dole at the East Oregonian.
Yeah, can you hear me?
Yep.
Can you hear me?
Yes, we can.
Okay, great. So yeah, just to walk back on that, I heard from officials in Morrow County yesterday that their vaccine shipments were being diverted because, like you said, they were essentially ahead of the curve, ready to move on and immunize elderly folks. They had to cancel 2 planned vaccine events because they now have such a limited supply. So I guess what I'm wondering is, can you confirm if or if not the doses promised to rural communities that have since been canceled, if those are being redirected to the Portland metro area? And if they are, can you tell us more about why? And I do have one follow-up.
Sure. So this is the point that I tried to cover there. It's actually it includes doses going to the Portland metro area, but includes a much longer list of counties than just that. And I went through those counties in my statement. Basically the reason is, if we have counties that have substantially finished the population of people who are eligible, we're redirecting doses to counties that have not received enough doses yet to finish that population before we move on to seniors. And so, if seniors aren't eligible yet, they don't start being eligible until February 8th. And so, if counties have finished the 1A population and the education, childcare, and early learning population, then we're using doses to go to counties that have not gotten enough vaccine yet to get that far.
Okay. And in light of that, so the state has consistently been saying that an equitable distribution of vaccine is the goal, that getting vaccine to areas and populations that are hardest hit and most vulnerable is most important. Morrow County's population is nearly 40% Hispanic, and this population has accounted for nearly 60% of the county's cases. Similar trends have been reported in Umatilla County, and these counties have the second and third highest testing positivity rates in Oregon. It's been the case for months. And yet they have received some of the smallest shipments of vaccine, and as a result, have some of the lowest immunization rates in the state. So I guess, what's your response to officials who are saying that by canceling or diverting these shipments, you're not fulfilling your promises of equity?
Well, I think the design of the 1A population is specifically done to include people who are workers in those categories who are more likely to be people of color, people who are more heavily impacted by the disease. And so if you think about healthcare workers, where we've broadened the definition to include not just licensed professionals, but people who work in a hospital who also come in contact with patients, like food service, environmental services, those kinds of things. If you look at the daycare population, that heavily skews toward populations disproportionately impacted by the virus. If you look at other parts of the 1A population, around home health workers, workers in long-term care, those populations heavily skew toward people disproportionately impacted by the population. Now, there may be a legitimate question about is any individual county really being as thorough as it can to get through those populations and get through those disproportionately impacted people. But the fact of the matter is, if a county tells me that all we have left is 50 bus drivers, and we sent Morrow County 100 doses because that's the minimum amount, I've got to send vaccine to other populations that are much further behind in the 1A category. Douglas County is a good example. It has a very low, if not the lowest, vaccination rate in the state. And the fact of the matter is there's not enough vaccine to vaccinate everybody who's eligible. And we're trying very hard to make sure that we get to as many people in these first two categories before we open to the next category. But there just isn't enough to go around. And it's going to be that way for weeks and weeks and weeks.
So you foresee further cancellations to counties like Morrow?
Well, we're going to, this was a 1 week change in our allocations based on what counties reported to us about where they were in the distribution. We're going to open up now for the next 4 weeks to 700-some thousand people across the state. And I anticipate every single county for a long while to need vaccine, and we'll get them that vaccine.
Question is from Lauren Dake at OPB.
Hi, Director Allen. Before I ask my question, could I ask you just to clarify once again the data that you are now reverting back to and providing? You said deaths by location and age groups, though, because age group is what you're doing in the aggregate dashboard, or are you doing specific ages? Like what specifically are you going to revert back to?
Sure. In the daily press release, we'll be providing daily data on age groups. So how many people today died from age 80 and up? How many died from age 70 to 80? I don't actually know what the exact bands we're using are. And then in the weekly report, beginning the week of the report that is for the week of the 8th, so I think that'll come out on about the 10th or so. We'll report that in Multnomah County there were 15 deaths by ages, and indicate the underlying conditions of those ages, and do that as part of our weekly report.
Okay, so still keeping the groups and not going to like specific demographic data. Okay, was the decision to change the way that the data was being provided a completely internal OHA decision? Did you consult with the governor's office beforehand or lawmakers? And also, just with the rate of deaths going down, as we've heard from Dr. Sidelinger today, why did you make this change now when you would assume, the workload would be decreasing by quite a bit as well?
Yeah, so the workload related to this has ebbed and flowed as cases have gone up and gone down. And while it's welcome that they're going down now, you've heard a lot about these variants being more contagious, and if in fact they take firm hold, more cases will mean more hospitalizations and mean more deaths. And so, we can anticipate that we'll continue probably in some kind of a cycle like this as we continue through the pandemic. I've been talking with our epidemiological team and our data analysis team for probably a month at least, if not a couple of months, around how to resolve this workload bottleneck so that we can get epidemiologists out of this work that they're doing to doing things that I think are more helpful for fighting the virus. We went ahead and I didn't have conversations about this with the governor's office. And they would prefer that we go back to reporting more of this information, which we're going to go ahead and do. I went ahead and I gave the go ahead, I think partly because we were on our way down in terms of fatalities. And so it seemed that doing it during a peak, while it would be helpful from a workload standpoint, also would look like we're trying to, change data in the midst of a spike, and I didn't want to do that either. So we tried to pick a point when deaths were on the way down to make that change. But it's really been simply about this bottleneck around these deaths and how to assemble this data day in and day out.
The next question is from Lisa Balick at Quinn.
Yes, good morning. Director Allen, have you, when it comes to the vaccinations relative to schools?
Sorry, go ahead.
Thank you, there. Relative to the vaccinations in schools, have you or will you look at vaccinating high school students 16 and up who can get the Pfizer vaccine, so there would be more protection for them and their families when they go back into the classroom, essentially the same protection given to teachers and school staff?
So to this point, we have not considered creating a special category for kids in school. As you observe, for kids over 16, they're eligible for the Pfizer vaccine, not the Moderna vaccine, and they would be vaccinated really as part of the general population when we move to that stage.
Next question is from Aaron Ross at OPB.
Hi, Patrick. I was just hoping to get a little bit more clarity again on the rollback. So, in future updates, will we be seeing, like in the weekly updates, will we be seeing the data presented in a way that is individualized, or will it be aggregated? So we will no longer be seeing like there was a death of a 73-year-old woman in Morrow County with underlying conditions. We won't be seeing like that spelled out.
Correct. It'll be aggregated data, both in the daily report and in the weekly report, but it'll give more geographic specificity and more information about, or it'll have the consolidated information about underlying conditions. The dashboard, though, I mean, really, there is a wealth of information at the dashboard, and the dashboard does what I think you have to do now with the daily reports, which is figure out when did the person die, add up the different categories to figure out what's the rate, what numbers of deaths and what are the trends for different ages and those kinds of things that we now do in that dashboard. And I think it makes that data more accessible for everyone.
Yes. So in terms of like just data availability, I mean, that is wonderful. And all of the data on the dashboard has been really useful just throughout the pandemic. But for the most part, most of us haven't been using that data in the mathematical way that you're discussing. That's the only place on any OHA publication or any government publication that acknowledges deaths of individuals and not as data. So how do you feel about that decision to depersonalize this data and to take the person who is dying out of the deaths?
You know, it is a hard call based on that. We are one of only 2 or 3 states that are reporting data that way, and at the end of the day, what I really need to figure out is what's the most effective way to use the resources that we have to fight the pandemic. I wish that I could dedicate resources to that kind of reporting on an ongoing basis, but I need those epidemiologists to do other work. And so while we've been a handful of states that have been able to report that, we really need to be able to devote our data analysis time to data that helps us fight the pandemic, and that's what we've tried to do.
Thank you.
We have time for one more question from Ben Bakken from the Lund Report.
Yes, I was hoping you could maybe talk a little bit more about herd immunity. For example, how critical is it for an individual county to reach a certain threshold of vaccinations versus the state as a whole? Maybe you could just talk a little bit more to that. Thanks.
Thanks, Ben. This is Dean Sidelinger. I'll take that initial question. When we talk about herd immunity or community immunity, it's really increasing the number of people who are immune to the virus, so that if you come into contact with someone, that it's less likely that if you are sick with the virus and could make others sick, that person has protection. So, that can be as small as looking at people who are vaccinated in an individual house, as you increase the number of people vaccinated, to looking at the broader community level. So certainly as a state, we want to increase the kind of community immunity across the state, but that is going to happen community by community. And that's why with this phased approach, as Director Allen has been talking, as different communities, different counties are finishing that, vaccinating those individuals, we're moving on to help other communities reach that same level so that we can bring up that community immunity across the state, so that regardless of whether you're in rural Oregon, the metro area, or anywhere else, that we're building up that immunity across your community and offering protection to all Oregonians.
Okay, that's all we have time for today. I want to thank you all for joining us and thank our guests for joining us and for their presentations. I want to let you know that we will have copies of the slides we presented today available through our regular daily media release, as well as links to the updated forecast. So thank you again for joining us, and hope you'll tune in to our next media briefing. Thank you.